Good afternoon, everyone. Last night I had a wonderful opportunity to have dinner with our keynote speaker. And throughout the dinner, she provided us with some critical questions to think about. And it was in that space of open thinking that I decided to draw from a statement that was made at the School of Divinity 25 years ago by our founding dean, Bill Leonard. And in Dean Bill Leonard's founding convocation address for the Divinity School, he advanced a compelling thesis. Sooner or later, all good instruction involves provocation, pressing us beyond our certainty, beyond ourselves, and demanding more than we ever dreamed possible. Inspired by Ralph Waldo Emerson's famed 1838 Divinity School address, Bill transformed Emerson's declaration into a guiding precept that would shape the scholarship, imagination, spirituality, and vision of a new divinity school at Wake Forest University. In light of our ongoing work at the intersections of health and at the intersections of faith and health, and our commitment to health justice, and extending the pioneering efforts of Dr. John W. Hatch, we can now adapt Bill's thesis into a question for our moment. What is pressing the faith and health communities beyond its certainty, demanding more than we ever imagined possible? Recasting this thesis into the form of a question opens up new horizons, new opportunities, and new possibilities that have not yet been revealed or realized. As the philosopher Hans-Georg Gadamer reminds us in his magisterial Truth and Method, to ask a question means to bring into the open. The openness of what is in question consists in the fact that the answer is not settled. A true intellectual and public health leader capable of guiding us through this space of this open question is our unique and indelible keynote speaker. Dr. Leandris Liburd is the acting director of the CDC's Office of Health Equity. She served as the Associate Director for Minority Health and Health Equity for CDC ATSDR since 2011. In this capacity, she leads and supports a wide range of critical functions in the agency's work in minority health, health equity, and women's health. She plays a critical leadership role in determining the agency's vision for health equity, ensuring a rigorous and evidence-based approach to the practice of health equity, and promoting the ethical practice of public health in communities vulnerable to health inequities. Dr. Liburd has been instrumental in building capacity across CDC and in public health agencies to address the social determinants of health and in identifying and widely disseminating intervention strategies that reduce racial and ethnic health disparities. She has skillfully executed innovative models of collaboration that have greatly enriched and greatly expanded the reach, influence, and impact of the Office of Health Equity, including the successful implementation of the Lewis Scholars Program and the James A. Ferguson Emerging Infectious Disease Graduate Fellowship. She is a respected public health leader who has, over the course of her career, championed community health promotion, chronic disease prevention, community engagement, eliminating health disparities, and addressing the social determinants of health. She has worked in public health at the local, state, and federal levels and has held a variety of leadership positions at the CDC since joining the agency in 1987. She is a widely published author who has published extensively on community-based public health approaches to chronic disease prevention and control, the influence of culture and gender on health beliefs and behaviors, and racial and ethnic health disparities. Please join me in welcoming this pioneer, this true health professional who will guide us through the open space of this question, Dr. Leandris Liburd.
Good afternoon, everyone. Can you hear me? Somewhere in the middle of the night, my voice and throat decided to do something, but we're not going to do that today. I want to first of all thank Dean Walker for the kind introduction, for the hospitality that all of his team has shown us. And also, I want to thank you for your vision for Wake Divinity. Being together both last night and today has just been like a watering place for me. So I really thank you so much for the invitation to be part of the 9th Annual Hatch Lecture and Symposium. Also want to thank Ms. Anita Holmes, someone who I have known and respected for a very long time, for her initial outreach to me about this year's lecture. And I cannot describe how honored and even overwhelmed I was by the invitation, as Dr. Hatch was my professor and mentor, and always a giant and man of great distinction. So if I could take just a moment of personal privilege to have this honor in the December of my own career took me back to the beginning when I first arrived at the now UNC Gillings School of Global Public Health, right out of my undergraduate program. Before I came to campus, I had been advised by Professor Walter Allen at the University of Michigan to be sure to connect right away with Dr. Hatch and Tony Whitehead, who, along with Ethel Jackson, were the Black faculty at that time. So whenever I would see Dr. Hatch in the hall or outside of his office, there was always a swarm of students around him, and I would just wait for the next time that I might be able to catch him and introduce myself. Finally, I made an appointment to meet with him, and when I came into his office, he said, and I quote, "I was wondering how long it was going to take you to come meet with me." And that was the beginning of our professor-student relationship. In fact, he established, we had a 1 credit hour course together that Dr. Hatch titled The Black Professional, during which he would give me articles to read, and then we would discuss them for 2 hours every Friday. Now, at the ripe old age of 22, I thought I had things figured out and spent lots of time arguing with Dr. Hatch about what my professional life would be like. Well, I've said before to him publicly and say it again today, Dr. Hatch, you were right about everything, and I was wrong about everything. And I would have given anything to have been able to spend 2 hours every Friday with you over the last 3 decades of my career. This time, I would listen and not argue, and even now I know the questions to ask. But thank you for your profound influence in my professional development and the rich and enduring legacy that you have had in public health, and particularly in improving the health of African Americans and communities of color everywhere. And I have humbly tried to walk in your footsteps. So God bless you. Thank you. I didn't plan to get emotional. I'm going to get myself together. Thank you all. Let me begin by saying the panels and the panelists have been just amazing and extraordinary. Oh my goodness. And I'm afraid that I'm just going to be, to use the expression, preaching to the choir. But in the spirit of this year's theme, Activating Change, Health Justice in the 21st Century, I want to reflect on just a few scholars who have been influential in my thinking and my practice, and reference one seminal public health event that has shaped the national focus on addressing health disparities and improving minority health. And this really kind of aligns with the initial panel of kind of what brought us here. And I want to talk about what brought me here. I will also offer some definitions also coming out of our first panel, and then highlight some of CDC's experiences working with faith-based organizations, and most recently during the COVID-19 pandemic. And then I will close by just simply reiterating the central role the faith community plays in concert with public health and healthcare to protect and promote the health of both their congregations and the surrounding communities in the pursuit of health justice. So as with all disciplines, the science, theoretical orientations, and praxis of public health has continued to evolve and refine in terms of our understanding of both the drivers of population health risk and also the solutions. And much of my foundation in what we now call health equity began in my public health training at UNC. At that time, the chair of the Department of Health Education, now Health Behavior, was Dr. Guy Stewart. Guy Stewart was an anti-apartheid immigrant from South Africa. He was also a clinical psychologist who was recruited to the University of North Carolina from UCLA School of Public Health in 1970. And that's a critical date to remember. His leadership in 1970 brought a fresh perspective and a new focus on the social causes of disease. I think what we now refer most often as the social determinants of health. But even in 1970, we were aware that it wasn't all about your individual behaviors, but that there were social causes. And so as health education department chair, he introduced what was called the action-oriented community diagnosis. And we all had to do a community diagnosis as students. And this was a strategy that he and other South Africans developed in the pre-apartheid 1940s. So it has since become a cornerstone of UNC's approach to community health education. A central theme of Guy's work was that human behavior is part of a multiple and complex behavioral system that involves psychological, social, and cultural antecedents. And we heard reference today to an ecosystem. Right? There's absolutely a public health ecosystem and a health behavior one as well. And he emphasized the role of culture in health, particularly among racial and ethnic minority groups, as he argued strongly that a primary reason for the failure of public health programs among so-called hard-to-reach populations, I haven't heard that expression in a long time, and I'm very happy. But he said it was because practitioners incorrectly assume they understand the culture of the target community. And so in his approach, improved health, increased community competence, and social change are all outcomes of effective community health development. And I want to say that again. Improved health, increased community competence, and social change, all of those things working together are outcomes of effective community health development. He advocated, however difficult, that the role of the practitioner in community health development be guided by as many of these themes as possible. And we have been challenged today to see that if we are to move toward equitable population health, that it is a layered, complex, and long-term commitment and engagement. So it goes without saying that Dr. Hatch is counted among the significant influencers through his more than 50 years of experience in the areas of faith, health, and community organization, always having a focus on underserved communities and social justice. Dr. Hatch recognized that the church could exert a wide-reaching influence in the lives of Black Americans through changing the behaviors, attitudes, and knowledge of individual congregation members, as well as through mobilizing changes in the larger social order, such as the powerful role of the Black church in the civil rights movement. Dr. Hatch's leadership in the community health centers movement and faith communities has been a model for decades as he explored ways for health professionals to leverage Black churches in promoting health and preventing disease. His work with Dr. Jack Geiger, who he has mentioned to me several times over the last 24 hours, in the 1960s at the Delta Health Center in Mount Bayou, Mississippi, proved the value of community health centers, especially in Black and rural communities. And I shared during another lecture that Dr. Geiger, when they were in Mount Bayou, he would write prescriptions for food. And, at one point, the Bureau of Primary Care, which oversees the community health center, said, "You can't do that. You can't write a prescription for food." And he said, "Well, last time I checked, the treatment for malnutrition was food." Well, that was in the 1960s. Well, now, today, we have what's called the Food as Medicine Initiative. So sometimes it doesn't happen when it needs to happen, and sometimes we look back to go forward, but we're making progress. So in the 1990s, last thing I'll say about Dr. Hatch, he provided his expertise to Project Direct, which was a community diabetes demonstration project in Southeast Raleigh where faith-centered strategies and local churches were applied to create both social and environmental changes to support diabetes prevention and control. Project Direct successfully involved historically Black colleges and universities and Black churches, demonstrating again how local institutional resources can be mobilized to eliminate health disparities. And I will argue again that we will be looking to these institutions in the future more than ever to continue to lead us into good health. Another important scholar and public health practitioner who has contributed to reducing health disparities is Dr. Larry Green and his work in defining health promotion. Dr. Green was the founding head of the Division of Health Education at Johns Hopkins, now Bloomberg School of Public Health. He was appointed by President Carter as first director of the Office of Health Information, Health Promotion, Physical Fitness, and Sports Medicine that coordinated the development of the Healthy People reports, which still inform the nation's public health policies today. Healthy People is the nation's health objectives, and he is the co-founder of the Precede Proceed model for public health program evaluation. Now, in 2000, he wrote a publication that health education and health promotion have a long history of being organized around settings such as healthcare, workplaces, and schools, which provide, and I quote, major social structures that provide channels and mechanisms of influence for reaching defined populations. And then he proposed 3 eras leading to health promotion policy. The first was the era of resource development, which was post-World War II, during which the U.S. heavily invested in building 3 types of health resources: scientific knowledge, medical facilities, and health personnel. This included biomedical research, the inauguration of the National Institutes of Health, new hospitals and clinics were constructed, but eventually the question arose, are these vast resources for medical care equitably distributed? I think we know the answer. The era of redistribution in the 1960s focused on equitable redistribution of resources, including the development of neighborhood health centers and the introduction of Medicare and Medicaid. And health education during this era was devoted largely to increasing the public's use of health service. And then thirdly, there was the era of cost containment, which started with efforts to decrease the cost of medical care and leveraged health education and public health by placing disease prevention and health promotion back on the policy agenda after decades of a national preoccupation with medical care resources and services. So do you see some cycling that goes on in our history? So health promotion of the 1980s shifted the focus from institutions and professionals to individuals and families. And Dr. Green suggested the health promotion of the 1990s could justify this by providing for increased community and social support for healthier lifestyles of individuals and families. But he also predicted that there would be a new emphasis on concerns with the environment and with housing and other conditions of living that shape the health-related lifestyle of individuals and families, which some would argue is the forerunner to our current focus on the social determinants of health. Now, fourth scholar, and this will be my last one, is Dr. Stephen Thomas at the University of Maryland, who categorized what he called 3 generations of health disparities research, and then he suggested a 4th generation. So Dr. Thomas and his colleagues examined patterns of disparities research, and they described the 3 generations as 1. The first was to understand data trends by documenting the existence of disparities. We still spend lots of time documenting disparities. The second generation, he said, was focused on explaining reasons for the disparities. That is, the factors driving the disparities. We spend a lot of time doing that as well. And the third generation is devoted to identify solutions for closing the health disparities gap. So we've invested lots in creating evidence-based solutions to persistent health disparities. But then Dr. Thomas proposes a 4th generation, which they call the Health Equity Action Research Trajectory, or HEART. And this model uses comprehensive interventions to address race, racism, and structural inequalities while also advancing evaluation methods. So we know that race is a social construct and lived experience. It is not a biological category. We have known that for a long time. But we now have an opportunity to really contextualize how we address health disparities and health inequities within a structural context. So lastly, I must mention the landmark 1985 Secretary's Task Force report on Black and minority health. Also known as the Heckler Report, this was the first federally sponsored epidemiological study of excess deaths experienced by racial and ethnic populations in the U.S. And it elevated minority health onto a national stage, bringing much needed attention to historical, costly, and largely preventable health disparities. So though representing different eras in public health and a variety of frameworks, we have frameworks today and theoretical and practice perspectives, there are clear cross-cutting themes in the work of these scholars that bring us to more contemporary approaches to pursuing health equity. So for as long as records have been kept, African Americans have experienced poor health status than their non-Hispanic white counterparts. We can consider the work of W.E.B. Du Bois and the Philadelphia Negro that was published in 1899. And then how we describe and explain these patterns also have evolved with more sophisticated research methods, data analytics, and other emerging measures of population health. So in terms of definitions, which are important to describe what we're pursuing and inform how we might monitor progress, I'll offer just a few. Health disparity. A health disparity is a plausibly avoidable systematic health difference that adversely affects a socially or economically disadvantaged group. And then we add that this definition does not require establishing that the health difference was caused by social or economic disadvantage. It requires only observing worse health in a socially or economically disadvantaged group. And when you observe that, you see that these are patterns that they can't be coincidental, but there is something that is underlying these persistent health disparities. Health inequities, and sometimes people like to use health disparity and health inequities interchangeably, but we suggest that health inequities are particular types of health disparities that stem from unfair and unjust systems, policies, and practices that limit access to the opportunities and the resources needed to live the healthiest life possible. And a good example of that is who has access to health insurance? Or as we were going through COVID, and I'll say more about that, who had access to paid sick leave? There were people who were going to work because they didn't have paid sick leave, and there were lots of exposures during that time. I won't say more about health justice because I think you all have really laid that out. But I want to now just talk about the importance of faith-based organizations in addressing health disparities and health inequities and in your pursuit of health justice. So how might faith-based organizations factor into? We've already said this is complex. It's going to take multiple sectors. It's going to take interdisciplinary approaches. So where do faith-based organizations fit? And more specifically, in this instance, where does the Black church also fit? Well, we know that faith-based organizations are uniquely positioned to create safe spaces for people to come together and talk about health and other issues impacting day-to-day life. And I know that much of the work of the Compass Center is to make it an even safer space. The church can be a refuge and a hiding place in times of great threat, and we saw this in full force during the COVID-19 pandemic. And I'll just remind you, early on, African Americans, Hispanics, and American Indians had the highest rates of COVID infections, hospitalizations, and deaths. And in many instances, it was because members of these communities worked in occupations where they had little control over their exposures to the public. So when we said everybody go home, everybody couldn't go home and work from home. And as I said earlier, occupations that were less likely to have paid sick leave and also had less access to health care, in addition to having comorbidities, going into a global pandemic with multiple comorbidities. And I can tell you, the pandemic exacerbated already serious health disparities. We've lost life expectancy and lots of other things that we now have to recover from. So we really need to get behind population health and really push to regain and then go beyond the previous health status that we had as a population and as a community. CDC during this time established an initiative titled Partnering for Vaccine Equity, and through a cooperative agreement funded a group of national organizations, including the Conference of National Black Churches, the Urban League, and there were others. And if you are not familiar with the Conference of National Black Churches, they have a membership of over 20 million people, including 30,000 congregations, and they represent more than 80% of African American Christians across the United States. So this partnership began in 2021 during the early rollout of the COVID-19 vaccine. And then the Conference of National Black Churches worked hard with congregations to dispel vaccine myths and to overcome hesitancy in African American communities by blending scientifically sound and scripture-based information on TV, radio, billboards, on the web, social media, as well as from the pulpit. And I don't know if any of y'all remember early on in the pandemic, people were saying that black people couldn't get COVID. Did y'all ever hear that? What? Why? Why not? People would say things to me, and I started to say, if you can't show that to me in a peer-reviewed journal, I can't talk to you, because some of this just defies any sense of basic biology, immunology, anything. Why not? So anyway, we heard a story. I went to a meeting of the Conference of National Black Churches, and Bishop Drew Sheard, who is he's the presiding bishop over the Church of God in Christ, quite a large denomination. And he shared, all right, he talked about, kind of during the pandemic and like when the vaccines were released, and some of his family members were like, don't you take that, don't you get that vaccine. And he kind of went behind their backs and got it anyway. But the Church of God in Christ became quite a vocal supporter and encouraged people, because he said his father died from COVID, and he said, my father wasn't sick. He was fine. And then, it was that COVID just like came out of nowhere and was taking people out. And then some weeks or months later, his mom died. So this has become like his campaign, right? And they have been very, very active in both the Conference of National Black Churches as well as on their own as a denomination. So recently, the Conference of National Black Churches coordinated several large-scale events with their partners. And I'll share these with you just so that you have some ideas for your own work. So they included HBCUs and would have health events during homecoming celebrations. They co-sponsor events at NFL games. They did back to school Black church vaccination events. They even had Juneteenth health fairs with churches, and also supported church and pastor anniversaries, adding in a focus on health, and then a variety of nonpartisan vote and vax initiatives. So collectively, over the past 3 years, these partners and their initiatives have made a significant impact on vaccine equity. And I will share some of this data with you. Working together, they administered over 2.4 million COVID-19 and flu vaccinations. They have successfully engaged more than 4 million people from racial and ethnic minority communities by engaging people in promotional events. They launched 674 educational campaigns in 45 different languages. They reached more than 572,000 clinicians and healthcare personnel through training and communication efforts, and they have trained over 410,000 trusted messengers. And we heard reference a lot today to trusted messengers. So we want to be sure that they are equipped with the right information and have a chance to really work with health professionals to be confident in that information before they go out in the community. So it goes without saying that churches are trusted sources of credible information to counter the misinformation and the disinformation that can and does run rampant in communities. So working in collaboration, and this has come up today as well, with state and local health departments, working with academic health centers, large health systems, and community health centers. Churches can continue to serve as places people can go for prevention services and other referrals for care and social services. So don't be shy about approaching these entities because they need you as much as you need them. So in closing, I just want to say, how do we sustain and grow the decades of work that have evolved to bring us to this critical juncture in our ability to achieve health equity? More than ever, we will have to look to enduring community institutions like faith-based organizations to protect and promote the health of communities. Community engagement is the cornerstone of good public health, but as Dr. Smallwood called out, we need to question who is represented and who is left out, and how are we defining community. And then we are challenged, and I'm the we, and my colleagues in state and local health departments are the we. We're challenged to find ways to work more closely with and be able to fund communities directly. because we know that these partnerships and collaborations are essential to building community trust. Also, we must leverage lessons learned from COVID-19, from the data and surveillance, from community engagement and partnerships. We need to leverage the strategies that came out of the pandemic, and we also need to really reinforce and just advocate for the policies and the authorities that we need in order to sustain population health. So from a just health standpoint, we have an opportunity to re-engage how we imagine what is needed to overcome historical and contemporary injustices by, first of all, valuing all people equally. And our definition of health equity, which I did not share, one of the subtexts is that we must value all people equally. And I believe when we come to that, we're halfway down the road, and then there's more work to do. And I do want to share very quickly, we have a communications group in our office, and they did some qualitative message testing to learn more about what people think, what they understand and feel about health equity, and how existing messages and definitions about health equity and social determinants of health are received by audiences. And let me just say, I was a bit shocked that people don't like that word. They don't like health equity. They don't like social determinants of health. Now, these are regular folk, not us here, right? They like that all people should have the opportunity to attain their best health possible. That's actually our definition of health equity. That piece, they're good. But it's the language did not sit with them. And so a key takeaway from our research was that health and health equity is accepted as a core belief that personal behaviors largely explain health outcomes, while the role of systemic factors were new to them. And potentially general audiences, it's new to them and therefore difficult to understand and accept. So audiences differed in their understanding of certain words like equity, equality, and social determinants of health, and many had pre-existing concerns about health equity concepts, including their own personal biases. So, and I heard Dr. Smallwood mention this last night, we came away with 3 concepts. First one, meeting the audience where they are. Second, communicating health equity as a we issue. Because the truth be told, when we achieve health equity, the whole society benefits. And 3, we need to frame health equity as achievable. Some people view it as an aspiration, a value, but not something that we will ever necessarily attain. So now I really am going to close. As we move forward, let us carry these lessons with us. Let's also celebrate the successes, acknowledge and confront the challenges, and remain steadfast in our commitment to ensure that all people have the opportunity to attain their best health. I know this is a tall order and there are many challenges ahead, but I cannot think of a better or bigger purpose for our work in public health than to realize the full potential of public health science, practice, and policy. So I will close with a quote from the book Long Walk to Freedom, which is the autobiography of Nelson Mandela. And he said this: I am fundamentally an optimist. Whether that comes from nature or nurture, I cannot say. Part of being optimistic is keeping one's head pointed toward the sun, one's feet moving forward. There were many dark moments when my faith in humanity was sorely tested, but I would not and could not give myself up to despair. That way lays defeat and death. I learned that courage was not the absence of fear, but the triumph over it. The brave man is not he who does not feel afraid, but he who conquers that fear. Thank you all so much for your attention.